Well, hello everybody and welcome back to Anatomy 1. Let's continue our discussion of the upper limb by going through the last regions that we have at the upper limb. And those regions are going to be the wrist and the hand. This is going to be lesson 7 in our plan. So now in lesson 7, we will learn about the wrist and we will go over the bones of the wrist and hand. The bones of the wrist and the hand should be reviewed for you since we have already been studying it in the first lesson anyway. So now we'll just have a little bit of a review before we're moving on to another structure that is one of the most important structure in this region, that is the carpal tunnel. The carpal tunnel, there are a lot of things going through this carpal tunnel, and there is particularly a very important nerve, which is the median nerve that goes through this tunnel, which is a very important thing that will have to be covered in relationship to a clinical correlate that we are going to have, which is the carpal tunnel syndrome, or CTS. Then we'll go over the hand. We'll talk about the fasciae, the palmar spaces of the hand, okay? The muscles, both extrinsic and intrinsic, even though the extrinsic we have already learned over in the antebrachial or the forearm part of our class in previous lessons. And then finally, we'll go over the neurovasculature of the hand. All right, let's go over the wrist, guys. So now the wrist is an important area of transition between the forearm and the hand. Okay, this is pretty obvious. Now, the wrist contains two major joints. One joint is right here, okay, which is the distal radial ulnar joint. But the more important joint is right here, in between the radius and the carpal bones. This joint is therefore called the radial carpal joint. And it is in between the distal end of the radius right here, as well as the three carpal bones, the scaphoid, the lunate, and sometimes the triquetrum, okay, when you have ulnar deviation. All right, so the movement of this radial carpal joint is very extensive, containing abduction and adduction, okay, containing flexion and extension, a little bit of supination and pronation, even though a lot of the supination and pronation happens actually at the elbow, okay? Now, because of this extensive movement, okay, this is one of the rare joints in the body, the radial carpal joint, that can do circumduction, okay, which is the movement of the joint basically of around and around in a circle, circumduction, basically. All right. So now, one of the things that is important for you guys to know sometimes, okay, is going to be the fact that the adduction and the abduction of this radial carpal joint is also called two other things, okay? Like, for example, if you have the adduction, okay, adduction of the radial carpal joint is also called ulnar deviation. Why? Because the joint is going to get the hand to go over closer to the ulnar side. Okay, so it's also called ulnar deviation. And in the reverse, you would call this motion the motion when the hand is guided towards more of a radial side as being either abduction or radial deviation. All right. This is going to be a very important concept, especially when you are talking about like the different position of the hand when you're doing certain x-rays. Like, for example, for scaphoid x-ray, you have to ulnar deviate the hand in order to get the scaphoid to show up clearly and by itself on the radiograph, basically. All right. So now let's review a little bit about the whole bony framework of both the wrist and the hand. First off, how many wrist bones are there? There are 8 of these wrist bones. And how are they aligned? They are aligned in 2 rows, right? 2 rows. Each row contains 4 of them, okay? From lateral to medial or from radial to ulnar, the proximal row is going to be scaphoid, lunate, triquetrum over here, and finally the pisiform. Note that the pisiform sits on the triquetrum, on the anterior side of the triquetrum like this. Okay, this is a very important thing. And notice how there is also something that is called the tubercle or the scaphoid right here. It is also quite important. The tubercle, the scaphoid, and the pisiform together makes up more of anterior projections, okay, of this proximal row of carpal bones. Now, there's also the distal row of carpal bones, which contains the trapezium over here, trapezoid over here, the biggest carpal bone right here, which is the capitate, and finally the hamate. Hamate is called like that simply because of the fact that it has a hook right here. Hammatus, okay, is an ancient word for a hook, and therefore you got the hook of the hamate right here, okay? So now look at the hook of the hamate and look at the tubercle, the trapezium right here. Those are also anterior projections on the second, the more distal row of carpal bones. And these anterior projections become very, very important because something will run from these anterior projections to the other side, like this. And this thing is going to be called the flexor retinaculum, FR, the flexor retinaculum, which is a very, very important. Why is that? Because if you would look at the rows of the carpal bones from anterior to posterior, this is what you will see. This is the more anterior side of the carpal, so of what is known as a carpal arch. And this is a posterior side of the carpal arch. Okay, why is it called a carpal arch? Remember when we talk about the anterior projections? They are here. Okay, on each row of carpal bones, there are anterior projections. Okay, and these guys are it, the pisiform, okay, and the tubercle of the trapezium right here. Okay, so basically, the carpal bones, either the proximal row or the distal row makes an arch that curves more posteriorly like this, okay? It curves more to the posterior side. So now these anterior projections, there is going to be a structure that runs between those anterior projections from lateral to medial. So what is this called again? Flexor retinaculum. Very good. And the flexor retinaculum is going to convert this carpal arch into something that is called the carpal tunnel. You see that? That space right there, that's the carpal tunnel. And the carpal tunnel has the property of connecting the anterior portion of the forearm to the anterior portion of the hand. And stuff have to go through that tunnel. So this tunnel is very important in order for stuff to go through, in order to get from the forearm to the hand. What things can try to get from the forearm to the hand? Oh, I can think of several, but we are going to actually look at it a little bit more in detail when we get more into, like, you know, the later slides, basically. All right, so now let's actually review a little bit about the hand bones and finger bones. First off, what are the hand bones called in scientific language? Metacarpals. Very good. So how many of the metacarpals are there? There are 5 of these guys, right? There are 5 of these guys. So what are those 5? One, the most lateral one is the metacarpal 1, okay? And this is the metacarpal of the thumb. Good. And then you have 2 right here, which is the metacarpal of the index. Very good. And then 3, which is the metacarpal of the middle finger. 4 right here. And then 5 right here, which is the pinky metacarpal. Okay, very nice. So there are 5 of them. So now, how many finger bones are there? But actually, first off, what are finger bones called in terms of scientific language? Phalanges. Good. Phalanges. Now, the singular form of that is phalanx. Okay, so how many phalanges are there in total? 14. Good. Why isn't it 15? Because there are only 2 phalanges of the thumb. Okay, everywhere else from digit 2 to 5, you have 3 phalanges. So the thumb only has the proximal and distal phalanges, while this, for example, the index finger and every finger after that is going to be proximal, middle, and distal phalanges. Okay, that's why there's 14 rather than 15. Okay, very, very good. And now we can move on. All right, so now let's look at a little bit of this image right here, okay? So remember, the carpal bones are going to be in this general area, okay? And a structure is going to extend right here on the anterior side between anterior extensions on the lateral side to the medial side. So what is this structure called again, number 21? What is that? That is going to be the flexor retinaculum, okay? And the flexor retinaculum is going to form the anterior part of the carpal tunnel, the anterior wall, basically, of the carpal tunnel. Very nice. All right, let's move on. So now look at that. Look at that. This is what we have seen before. The carpal arch is right here. You see that? And then there's a flexor retinaculum extending more anteriorly. This is anterior, this is posterior. Very nice. And then you have the carpal tunnel. That is this space right here that things can go through. So now, what are the things that go through this carpal tunnel? Let us go ahead and look at the image on the right side. Okay. Here you have the anterior side, and this is the more posterior side. You have the flexor retinaculum that is going to go right here. Okay. And then you have the carpal arch that is extending back here on the posterior side. So now, things in the carpal tunnel are going to be some tendons, right? And then there is a nerve right here. Okay. So now, what are those tendons? They are the tendons of the flexor digitorum superficialis. And the tendons of the flexor digitorum superficialis is going to be divided onto two layers. Okay, there's going to be an anterior layer right here and a posterior layer. Each contains two, okay, of these tendons. These two are going to the digits. It's going to be to the digits 3 and 4. And these two are going to be to the digits 2 and 5. Okay, actually it's reversed, isn't it? Sorry about that. This should be 4 right here. This should be 3. Okay, so the second and fifth tendon, okay, the tendons of the flexor digitorum superficialis going into the second and fifth digit are going to be the more posterior row. Okay, and the ones to the third and fourth digit are going to be a more anterior row. Okay, and that's how these tendons are going to be divided as it goes through the carpal tunnel. And deep to that, you have the tendons of the flexor digitorum profundus. Okay, these 4 right here. You also have the tendon of the flexor pollicis longus. That's right here. And alongside of those tendons, you also have their sheets. Okay, there's tendon sheets. Okay, as well as bursae. That basically surround these tendons. Okay, and these tendons share the space inside the carpal tunnel with an important nerve, which is the median nerve. Okay, which is the median nerve right here. Okay, and now, which lead us to a very important clinical correlate, that is carpal tunnel syndrome. Okay, carpal tunnel syndrome. And carpal tunnel syndrome is what happens when there is an increase in the pressure inside of the carpal tunnel, leading to a compression of the median nerve. Okay, and when median nerve over here is compressed, it's going to cause some distal symptoms over at the fingers. More specifically, you will have a decrease in the feeling, okay, of the thumb, okay, and the palmar side of the thumb, okay, the skin of the palmar side of the thumb basically, and the skin of the palmar side of the index finger, the middle finger, and 1/2 of the ring finger. Okay, and there would be a diagram that will show you a little bit better as we get on over to like the distal parts of the hand later on. Okay, and then also the compression of the median nerve over here can also lead to the weakness of the muscles of the thumb called the thenar muscles. And we will see that also when we get over to the hand. Okay, and this compression of the median nerve inside the carpal tunnel, we call it carpal tunnel syndrome. Okay, so that's what carpal tunnel syndrome is, and that is why learning about a carpal tunnel here is very important. One important note that you guys need to know is that the ulnar nerve does not actually pass through this carpal tunnel. Look at it. Ulnar nerve is actually right here. It doesn't go through the carpal tunnel at all. Okay, but it will go through another canal. Okay, it will go through another canal, but it's not going through the carpal tunnel. Okay, instead it will go through its own canal, that is the Guyon's canal. Okay, the Guyon's canal is more on the medial side of the hand, okay, the distal part of the wrist, basically. Okay. All right, let us move to the hand now. For the hand, right here, is the region of the upper limb that is distal to the wrist joint and is also the most distal region of the upper limb. And the hand actually have two surfaces. On the anterior side, which is this surface, is going to be called the palm or the palmar surface of the hand. On the posterior side, as you can see here, we have the dorsum or the dorsal surface of the hand. Okay? Now, most of the components of the hand will be associated with this surface here, which is the palmar surface, which is also the anterior surface. The thumb is going to be most lateral, and due to its proximity with the radius over here, it's also called the radial side of the hand. And then you have the opposite, which is the medial side, also called the ulnar side of the hand, right here. All right, let's talk a little bit about the fascia of the hand. Now, proximally, the fascia of the hand is actually continuous with the antebrachial fascia. It is quite thin, as you can see here, over the thenar surface and the hypophanar eminences right here and right here. Now, the thenar eminence is the eminence that contains most of the muscles of the thumb, the intrinsic muscles of the thumb, I should say. And then you have the hypophanar eminence, which is right here and contains a lot of the muscles that are associated with the little finger. Okay, so the thenar eminence is going to be on the radial side, and the hypophanar eminence is going to be right here on the ulnar side of the hand. Now, these two regions, the fascia, are very thin, but in the middle, right here, as you can see, it is very, very thick, and it forms what is known as the palmar aponeurosis. Okay, and in the digits, they form what is known as the fibrous digital sheets. Okay, so as you can see over here, when we're taken off the palmar aponeurosis, when we take off this structure right here, then you can see there are these fibrous digital sheets that surrounds each of the digit right there. Okay, let's talk a little bit about the palmar spaces. There are a lot of fascia in the palmar surface of the hand, and those fascia, they not only form the palmar aponeurosis, but also they form compartments, okay, within the hand itself. And they divide the compartments from each other by making a wall, basically, in between them. Like, for example, you have two prominent septa, or two prominent walls within this palmar surface of the hand. Number one, you have the lateral palmar septum. So the lateral septum is the one that extends from the lateral border of the palmar aponeurosis, which is right here, over to the first metacarpal bone, right here. And then you have the lateral septum, right here. Oh, I'm sorry, I got it backwards, okay? So this is the medial septum, okay? The medial septum is right here, which extends from the medial border of the palmar aponeurosis, which is this part right here, over to the fifth metacarpal bone, which is this bone right here, okay? And there is the lateral palmar septum right here that extends from the lateral border of the palmar aponeurosis all the way to the first metacarpal bone, okay? My mistake. All right. And with these two septa, here and here, it divides the hand into the thenar compartment right here, the hypophanar compartment right here, the middle compartment right here. Okay? So now, let's just see where these septa are on this image. One septa is going to be around right here, which is the lateral palmar septum. And then the other septum is right here, which is the medial palmar septum. And it divides the palmar surface of the hand into three surfaces that you can right away see, into three compartments that you can right away see when you take up the skin of the hand, okay? There is the thenar compartment, which is the compartment that contains most of the muscles for the thumb, right? And then you have the hypophanar compartment right here that contains the muscles that is going to control the little finger right here, okay? And in between them, there is a middle compartment. But in this middle compartment is actually quite complex because of the fact that the middle compartment, or the central compartment, if you will, is going to contain more than just what you see over here. Okay, there will be deeper and deeper layers, and some of those deeper layers will also form their own compartments, as you will see in the next image. Okay, so for the next image right here, we can once again see this is a lateral fibrous septum. Okay, this is the medial fibrous septum right here. It divides the palmar surface of the hand into the thenar compartment, which is right here. Okay, and the hypothenar compartment, which is right here, as well as the middle compartment, which is right here. But then again, the middle compartment has just way more than just the surface level on the anterior surface, as you can see here. It also contains a compartment that is deeper, and also the deepest compartment. Okay, and this is called the adductor compartment. This adductor compartment is the deepest compartment on the palmar surface of the hand, and it contains the adductor pollicis muscle. And then you will also have this compartment right here. Okay, this compartment contains the muscles that are in between the metacarpal bones, okay, from 2 to 5. And these things, okay, these muscles right here, because they are in between the metacarpal bones, they are called interossei muscle. And because of that, this compartment right here is called the interosseous compartment, and it's the most posterior, okay, and it will contain the interossei muscle. Now, you also have these two notable potential spaces that are present on the palmar surface of the hand. One is this green space right here. One is this green space right here. That's called the thenar space. Okay, and it's between the thenar compartment right here and the adductor compartment. And then the second compartment, space. And then the second space is this space right here, which is also called the mid-palmar space. And it lies between the middle compartment right here, the central compartment, if you will, and the interosseous compartment right here. All right, now let us go to the muscles of the hand. So the muscles of the hand are divided into extrinsic muscle and intrinsic muscles. Now, the extrinsic muscles are the muscles that come from somewhere else that inserts on the hand. And we have already learned about a lot of them, actually all of them, when we talk about the forearm, okay, the anterior and the posterior forearm. Okay, so the extrinsic muscles come from the forearm, and you have the flexor muscles, which are, as a reiteration of last lesson, anteriorly located. So they are more anteriorly located. That's why they are flexor muscles. Okay, the flexor muscles are always anteriorly located. Okay? Now, a lot of these flexor muscles originate from one point on the medial side, okay, which is the medial epicondyle of the humerus, all the way up here. Okay, and it's going to divide it into layers. There are 3 layers. Okay, and in the first layer, the most superficial layer, you have 4 muscles. The middle layer have 1 muscle, and the last layer, the deepest layer, have 3 muscles on the anterior side of the forearm, as we have already studied before. Then you have the posterior extensor muscles, okay? And these extensor muscles, they are laterally and posteriorly located, okay? A lot of them originated from opposite of the medial epicondyle, which is the lateral epicondyle. And they are divided into 2 layers, and each layer contains the 7, okay, which is a more superficial layer, and then 5 on the deep layer of muscles. Now, we will talk way more in this lesson about the intrinsic muscles. The intrinsic muscles actually arise from the hand itself. They originate and they insert at the hand itself, okay? And they will be divided into 4 thenar muscles, which are basically thumb muscles, if you will, okay? So these will control the thumb. And then you have the hypothenar muscles, 4 of them, that contains the pinky finger, or the little finger, if you will. And then you have 4 lumbrical muscles. And then you have 3 palmar interosseous, and 4 dorsal interosseous muscles. Okay, so now let's talk about the thenar muscles. Those are the muscles that control the thumb. Okay, and those thenar muscles are 4. There are 4 of them. 3 is actually located right at the thenar eminence, or the thenar compartment. But one of them, the adductor pollicis, actually is located in the adductor compartment of the palmar surface. And those 4 thenar muscles, and the 4 intrinsic thenar muscles are as follows. Number 1, you have the abductor pollicis brevis, which is the superficial one right here. And when you cut that off, you will see that there is also a muscle that is underneath that, more deeper. And you got the opponens pollicis muscle, which is the deeper muscle to the abductor pollicis mentioned above. And then more medial to the abductor pollicis brevis muscle, you also have the flexor pollicis brevis muscle that is right here. And finally, you have the adductor pollicis muscle, which is this huge muscle right here that is actually located within its own compartment deep to the thenar eminence. So now, the collective action of these 4 muscles are going to be the opposition and fine motor movement of digit 1. How do you know which muscle does which motion? Just look at the name. Abductor pollicis brevis. What would that do to the thumb? Will abduct it, right? And then you have flexor pollicis brevis. What will it do to the thumb? It will flex it, right? And why the brevis? Because we have already learned about the flexor pollicis longus that is actually located on the anterior forearm, as we have already previously seen in the last lesson. How about the adductor pollicis? Adductor pollicis will adduct the thumb, right? And finally, what does the opponens pollicis do? It is going to make the thumb be able to opposite the pinky finger, okay? We call it thumb opposition. And it is something that only the higher primates, such as, I misspoke actually. That is something that is that's only human has the ability to do, okay? Not even the higher primates has the potential to do this motion, except for human beings. Human beings are the only one that can do this. So now, all of these muscles, okay, are going to be innervated by the median nerve, okay? And with the recurrent branch of the median nerve, except for the adductor pollicis. The adductor pollicis, because it's located more medial than the rest of the muscles, as well as deeper, is actually innervated by the ulnar nerve, okay? All right. Okay, so in this chart right here, you can see that everything that we have talked about before. Again, I shall not go into detail on everything over here. It will be your responsibility, okay? But the thing is, just look at the name, okay? And the name will tell you exactly what the action of the muscles are, okay? And remember, every single one of them, except for adductor pollicis, is going to be innervated by the recurrent branch of the median nerve, right here. The adductor pollicis itself is innervated by the deep branch of the ulnar nerve, which is right here. Okay, so now let's switch gears. Going from lateral to medial, we have the hypothenar muscles, which control the pinky finger, or the little finger, if you will. There are 4 of them, but more often than not, you will see 3 right here. The abductor digiti minimi, the flexor digiti minimi brevis, and the opponens digiti minimi. So how do these guys compare? Number 1, you have the abductor digiti minimi, which is the most lateral and superficial. Then you have the flexor digiti minimi brevis, which is more lateral than the abductor digiti minimi muscle, okay? And then the deepest muscle is the opponens digiti minimi muscle, okay? And if you notice very carefully, this is almost the same as the orientation that you have on the thenar muscle, okay? Except it's a little bit opposite, okay? The abductor digiti minimi muscle, okay, is located the most medially, while the abductor pollicis brevis muscle is located the most laterally, okay? And if you look at the orientation of these muscles, they're the same. The opponent's digiti minimi, just like the opponent's pollicis muscle, is always going to be the deepest one over here on the eminences, okay? So this is one thing that you can use in order to study these a little bit better. Now, there is a fourth muscle, the palmaris brevis, which in some people isn't even there, okay? But it does exist in some people, okay? And the palmaris brevis is just simply, let's see if I can find a picture of it, right here. There is the palmaris brevis, which supposedly go like this, okay? And it's actually, if it's present, then it's actually going to be the most superficial muscle of the hypophonar compartment. All right. So now, what are the collective action? What is the collective action of those hypophonar muscles? So this collective action is the opposition and fine motor movement of digit 5, aka the pinky finger. Okay, and they are all innervated by the ulnar nerve. There is no exception here. And this basically summarizes what we have just talked about. Just look at the name. Okay, just look at the name, and the orientation is almost the same as that of the thumb, except for palmaris brevis, which is the most superficial muscle. Okay, and they are all going to be innervated by the ulnar nerve. Look how, because this palmaris brevis muscle is more superficial than the rest. Instead of being innervated by the deep branch of the ulnar nerve, just like every single one here, it is actually innervated by the superficial branch of the ulnar nerve, should it be present. Okay. Now, lumbrical muscles. So there are 4 lumbrical muscles, and they are first lumbrical muscle here, the second lumbrical muscle here, the third right here, and the fourth right here. Notice how there is a little bit different in terms of in terms of shape, right? In terms of morphology. The first 2 lumbrical muscles, 1 and 2, okay, 1 and 2, these guys right here, they're just like one slip of muscle, right? But these third and fourth lumbrical muscles are actually bipennate muscles, okay? And this is one thing that can help you, okay, distinguish which one is which on a cadaver dissection, basically. And also, you want to know which one is which because functionally and innovatively, they are also different, okay? 1 and 2 are going to be innervated by the median nerve, while 3 and 4 are going to be innervated by ulnar nerve, okay? So they are functionally and innovatively different as well. So now, 1, 2, 3, 4, the 4 lumbrical muscles, they all originate from the tendons of the flexor digitorum profundus. Okay, so they are arising from the tendons of the deep flexor muscle that comes from the forearm. Okay, the collective actions of these guys is going to be flexing the digit at the metacarpal phalangeal joints and extend the interphalangeal joints. So basically, they make the hand looks kind of like this. Okay, make the hand look kind of like this. Okay, so they basically extend the interphalangeal joints like that, but they flex. Okay, but they flex the metacarpal phalangeal joint. Okay, it's just like that. And you will soon find out that not only these lumbrical muscles help do this action, but also the interossei muscles as well. And this will come in very, very much handy when we talk about a nerve damage that is going to be mentioned later on. So now, the lateral 2 are going to be innervated by the median nerve, just like I said, and the medial 2 are going to be innervated by the ulnar nerve, just like I said. Now, the interossei, or the interosseous muscles, okay? They're called interosseous because they span the distance between metacarpal bones, okay? Now, they are arranged into 2 layers, a palmar layer, which contains 3 palmar interossei muscle, and a dorsal compartment, okay, a dorsal layer, which contains 4 dorsal interossei muscles. So now the dorsal interossei muscles, they abduct the digits and assist lumbricals in flexion of the MCP and extension of IP joints. So this one helps the lumbrical in the same action that we have seen before here. However, they also abducts the digit. So dorsal interossei abducts. So you have DAB, right? DAB, okay? So they abduct digits, DAB, okay? DAB. Then you have palmar interossei. The palmar interossei, what do? They adduct the digit, okay? And assist the lumbricals in the flexion of MCP and extension of IP joints, which is this action right here. So you see, a lot of muscles actually does this action, and that will come in very much handy, okay, when we talk about a nerve damage that will be coming up. The innervation of all of these guys is the ulnar nerve. Keep this in mind, guys. It's very important. All the interosseous muscles are going to be controlled by the ulnar nerve. Okay, very, very important stuff to keep in mind. So now, one last thing before we move on. The palmar interossei adducts the digits, right? So what do we have? Pad. So a mnemonic for you to remember the action of the dorsal interossei and how it's different than the palmar interossei are going to be DABs and pads. Okay. All right. Just so we reiterate what we have just said in the previous slide. Okay. The palmar interosseous muscle is going to do adduction because pad, and the dorsal interosseous muscles are going to do abduction as of DAB. Okay. All right. Okay. So now we'll go on to talk briefly about this structure right here, which is the extensor hood, and by extension, the extensor extension system as well. Okay. So the extensor hood is a system, okay, that allows a fine degree of motor control of the distal tip of the fingers during flexion and extension. So now those structures, okay, like for example, the interosseous muscle right here, as well as the lumbrical muscles right here, notice how distally they all converge into this structure that is right here, okay? And that is called the extensor hood. And the extensor hood also receives the extensor tendon up here, okay? And then after that, all of these tendons go into the extensor hood, and the extensor hood is going to extend out by several bands. These two on the lateral sides, they are called the lateral bands. And these lateral bands are actually going to extend a little bit further, okay? And insert by a terminal band right here onto the base of distal phalanx. Now, there is also a central band in the middle, but the central band extends a little bit shorter, okay, a little bit less distally than the lateral bands. The central band actually just extends over here to the base of the middle phalanx, and that's it. All right, and so when you look at it, you can see that the two lateral bands are right here. The central band is right here, and the central band actually extends just a little bit less distally than the lateral bands does. Okay, but what this contraption, the extensor hood and the extensor extension, okay, allows you to do is the fine motor control of these joints. Okay, and one more thing is that it also receives the lumbrical muscles, tendons, as well as the tendons of the interossei muscles. And so the extensor hood will help massively with doing this motion right here. The motion that we have talked about time and time again. Flexion of the metacarpal phalangeal joint and extension of the interphalangeal joints, just like this hand suggests. And now, almost all of these muscles that does this action, okay, all the interossei muscle, as well as the two lumbrical muscles of the two lumbrical muscles on the more medial side, 3 and 4, the third and the fourth lumbrical muscles. Which nerve control all of those guys? The ulnar nerve, okay, the ulnar nerve. So now if the ulnar nerve is damaged, what would happen? What do you think would happen? Well, if the ulnar nerve is damaged, then the reverse of this motion is going to occur, isn't it? The reverse of this motion, what would that be? It would be the extension of this joint right here and the flexion of all of these joints right here, okay? So that is going to be the hand, like that, okay? Each of these is an interphalangeal joint, okay? And this is the extended metacarpal phalangeal joint. And all of the interphalangeal joints over here is going to be flexed like this. What does this look like to you? A claw, isn't it? It looks like a claw. And so because of that, the ulnar nerve injury can result in what is known as a claw hand, okay? A claw hand. And a claw hand is what happens when you lose control of this whole contraption, and instead of doing this motion, you actually do this motion instead, okay? And that is why the ulnar nerve is very important in terms of how the claw hand will appear clinically, okay? And so in clinical setting, if you see a claw hand, chances are it's going to be an ulnar nerve injury. All right, so let us just reiterate back about the lumbricals and the interossei muscle, okay? And there are 4 lumbricals, and there are 4 dorsal interossei and 3 palmar interossei, okay? Dorsal interossei does what? It will abduct, dab, right? How about palmar interossei? It will adduct, pad, right? And the lumbricals, okay, as well as both the dorsal interossei and the palmar interossei, they all do one action, which is flex metacarpal phalangeal joints, extending interphalangeal joints. Okay, right there. They all do this action, but the dorsal interossei also abducts, and the palmar interossei also adducts. And look, what is the nerve that controls the majority of these muscles? Ulnar nerve. Ulnar nerve. Ulnar nerve. Okay, very important that you understand this. Okay, now the lumbricals does have a little bit different in terms of innervation, in that the lateral 2 lumbrical muscles, 1 and 2, are going to be innervated by the digital branches of actually the median nerve. Okay, so those 2 don't fall in line like the other one, or the other 2, like, you know, the ulnar nerve injury, innervated ones. All right, so now let's move on from the muscles and talk about the arteries and veins, as well as nervous innervation of the hand. Okay, so the arteries of the hand, first of all, are going to be derived from the branches of the radial and ulnar arteries. Remember when we talk about the forearm, the radial artery will run on the radial side, which is the lateral side, okay, of the forearm. Ulnar artery is going to run on the ulnar side or the medial side of the forearm, okay? And all of the branches of these 2 arteries provide all the blood to the hand. Now, for the hand arteries, it is very important that you recognize 2 very important structures. Number 1, it is called the superficial palmar arch. And number 2, it is called the deep palmar arch, okay? And the contribution in making these arches are different, okay? The superficial palmar arch is mostly going to be ulnar artery, okay? The ulnar artery will contribute more substantially to the superficial palmar arch, while the deep palmar arch is going to be contributed more substantially by the radial artery, okay? So radial artery is going to provide much more of an input into the deep palmar arch, while the superficial one is ulnar artery input mostly. Okay, very, very important stuff. But now let us go through each of these arteries, the radial artery and the ulnar artery, and we will see what would happen. Okay, so now the radial artery is the smaller of the 2 terminal branches of the brachial artery. Okay, and the brachial artery will divide into the radial artery and the ulnar artery, where the head of the radius way up in the proximal forearm. Okay, very, very way up. And then when it gets close to the hand, the radial artery is going to give off some branches. Number one, it will give off a superficial palmar branch, okay? And this will form the superficial palmar arterial arch. Now, then, when it gets to the hand itself, the radial artery is going to give off the princeps pollicis artery. The princeps pollicis artery, just like its name suggests, will supply the thumb because it has pollicis in it, right? And then after that, the radial artery will then give rise to the radialis indicus artery. And the radialis indicus artery will supply the index finger, but not all the index finger, only the lateral side of the index finger, okay? Radialis indicus. And then finally, the radial artery will curve to become the deep palmar arch, okay? Now, the deep palmar arch will give rise to some other arteries that travels to the fingers as well. The palmar metacarpal arteries, okay? And then you have the common palmar digital arteries, okay? And so those are the branches of the radial artery. Now, the ulnar artery is the larger one, okay? Now, it will enter the palm on the lateral side of the ulnar nerve, superficial to the flexor retinaculum, okay? And when it gets to the hand itself, after it passes lateral to the pisiform bone, it will form these two branches. Number one, the deep palmar branch, okay? Remember, the deep palmar branch is mostly what? Radial artery. But the thing is, in order to make it an arch, you need two arteries to make it an arch, right? And so the deep palmar branch, you have the radial artery mostly, but this one here, the deep palmar branch, okay, of the ulnar artery also comes into forming the actual full arch of the deep palmar arch, all right? Even though the deep palmar branch here is much smaller, okay, much smaller than the deep palmar arch branch of the radial artery, okay? So now, next up, the second one is the superficial palmar arterial arch. And this is the main contribution to the superficial palmar arch. And then, if you still remember in the radial artery, you have the deep palmar, you have the superficial palmar branch, which is the smaller branch that completes the superficial palmar arch. So now, let us see every single thing that we have just said in the form of pictures, okay? A picture is usually worth 1,000 words, and I really, really much agree during this particular matter because you can see these arteries way up close and way better, okay? So now, first off, look at the radial artery over here, okay? The radial artery over here. And the radial artery is going to, over here, when it gets to the hand, is going to give off this branch right here. You see that? And notice how small this branch is. This is the superficial palmar branch of the radial artery, okay? And when it comes over here, it joins with the much larger artery from the ulnar artery that makes up the superficial palmar arch, okay? So this larger artery is actually called the superficial palmar arch. But this one right here with the arrow, that's the superficial palmar branch, okay? It's smaller. Okay, so now that is the first branch, the superficial palmar branch, okay, of the radial artery. And then from there on, the other branch that branches out from that bifurcation is way larger. Look at that, is way larger right here. And that right there is the deep palmar arch, okay? The deep palmar arch branch of the radial artery. But it alone cannot complete the arch. But there will have to be, from the ulnar artery, this small branch right here, the deep palmar branch, okay, of the ulnar artery that goes in and completes that arch. You see that? So these two arches, the superficial palmar arch and the deep palmar arch, are the ones that supplies most of the palmar surface of the hand, okay? Which is basically almost all of the hand. Because why? Because almost everything in the hand is located on the palmar surface. All right? This is very, very important stuff, guys, and you need to understand that. Now, radial artery, when it gives out the deep palmar arch, okay? from the deep palmar arch, you will see these arteries coming out. This one is princeps pollicis, which goes to where? The thumb. And this one is the radialis indicus. Where does it go to? The index finger. But not all the index finger, only half of the index finger. Okay, and so this half of the index finger, as well as the thumb, we call them mainly radial artery supplied. Why is that? Because of the fact that there is this branch and this branch right here that supplies these structures. And so this is mainly radial artery. Now, the other part of the hand right here, because these ones, all of these ones are branches coming out from where? The superficial arch. And which artery gives rise to the majority of the superficial arch? Ulnar artery. And therefore, the superficial palmar arch, because they give off these branches, this part of the hand from the medial part of the index finger, this part right here, okay, all the way to the pinky finger are all ulnar artery mainly supplying them, okay? And that is the reason why people say that this part of the hand right here is mainly radial artery supplied, while the other part of the hand is mainly ulnar artery supplied, okay? So don't get confused, you guys. This is a very easy concept to be confused, okay? But the superficial palmar arch and the deep palmar arch comes from respective arteries, the ulnar artery and the radial artery respectively. But then there are superficial palmar branches and deep palmar branches, okay, that comes from the opposite artery that contributes to arch formation, okay? This is a very important concept. Okay, so these pictures basically show you guys the same thing that we have talked before, okay? And then on the dorsal surface, we have the dorsal carpal arch right here, okay, that gives rise to all of these arteries on the dorsal side that runs just like the ones on the palmar side. These are called the dorsal digital arteries. And the ones on the palmar side are called the palmar metacarpal artery, and then giving rise to the proper palmar digital arteries that runs on either side of the fingers, each finger, basically. All right. How about veins? How about veins? So just like arteries, okay, there are veins on the palmar side and there are veins on the dorsal side, okay? Now, the superficial and deep palmar arterial arches are accompanied by vena comitante. Basically, what this means is that these veins accompany the superficial and deep palmar arches. So they go together, okay? So you can imagine that all of these arteries right here are going together with a vein, okay? These veins are going to accompany these arteries on the palmar side. So that's easy. But on the dorsal side, there is what is known as the dorsal digital veins, okay? Coming from the fingers. Digital means fingers, right? Dorsal digital veins coming from the fingers, and they coalesced or they form tributaries, okay? That leads back to these two veins, one on each side. This vein here and this vein here. And these two veins are the basilic vein on the medial side or the ulnar side, okay, of the hand, and then the cephalic vein, which is on the radial side, okay, or the lateral side, okay, of the hand. And these two veins, these two superficial veins, will continue to go more proximally until they join, okay, with the axillary vein, okay? They join with the axillary vein and the axillary fossa that we have learned before, and go into the axillary vein and help makes up the subclavian vein, okay? So these veins are very important simply because of the fact that most of the venous return from the upper limb are carried out by these superficial veins, okay? We have superficial veins and then we have deep veins, okay? These are the superficial veins of the upper limb, okay? And these actually are going to transport most of the venous blood from the hand, as well as all the structures from the upper limb, back to the axillary vein in order to convert it into the subclavian vein later. So these are very important. All right, so now we're talking about nerves, and this is the last portion of our class today. We will talk about three nerves: the median nerve, okay, the radial nerve, and the ulnar nerve. So let's begin with the median nerve, okay? Now the median nerve, just like we said before, it goes through where? It goes through a tunnel. What tunnel is that? The carpal tunnel, okay? But what I did not tell you is that there is a branch right here of the median nerve that actually did not travel through the carpal tunnel. This is called the palmar branch. And what the palmar branch is going to innervate is the skin region right here. Okay, it's the skin region right here on the lateral side of the majority of your palm. Okay, this region right here is going to be innervated by this palmar branch of the median nerve. Why is that important? Because of the fact that if you have carpal tunnel syndrome, this part right here of the median nerve is going to be affected, and everything that is distal to it is going to be affected as well. But this palmar branch is not going to be affected. And so if you have carpal tunnel syndrome, you can still feel, for example, if somebody's pinching that area of your skin, simply because of the fact that the palmar branch does not go through the carpal tunnel. Okay, this is a very, very important clinical core that gets asked all the time. Okay, so you need to understand this. But then look at the median nerve and how it innervates everything else as it goes through the carpal tunnel. Okay, it can go over here and innervates what? Abductor pollicis brevis, okay, flexor pollicis brevis, and opponens pollicis. Okay, so basically the median nerve is going to innervate opponens pollicis, okay, abductor pollicis brevis, flexor pollicis brevis, and then there will be a branch right here that goes into these two lumbrical muscles, like we have said before. So L1, 2, OAF, or a loaf of bread. That is what the median nerve is going to innervate when it comes to muscles. Okay, so muscular innervation is going to be L1, 2, OAF, first and second lumbricals, and the opponents, the abductor, and the flexor pollicis. Okay, and those muscles are all going to be innervated by the median nerve. How about the skin region? The skin region that is going to be innervated by the median nerve is going to be that skin region right here. You see that? That is from the innervation for the palmar branch of median nerve. And then the skin region on your thumb, okay, the palmar surface of your thumb, okay, the palmar surface of your index finger, middle finger, and 1/2 of your ring finger. That is going to be the territory that is going to be supplied by the median nerve. So if somebody have carpal tunnel syndrome, something here is problematic, okay, then eventually they will lose feeling over this green area right here. Not this red area though, because this is palmar branch, but everything else right here, as well as on the dorsal side of the tip of the thumb, the tip of the index, the tip of the middle, and the lateral half of the tip of the ring finger. Okay, those are going to be the skin feelings, okay, or the skin sensations that gets acts off if the median nerve is damaged, like for example, in a carpal tunnel syndrome. Okay, very important. Okay, so now the ulnar nerve, right? The ulnar nerve is a little bit different, okay, than what the median nerve is. In terms of muscles innervation, okay, the ulnar nerve will send branches all over this, and it will innervate what? The hypophenar eminence, as well as all of the muscles in the hypophenar eminence, as well as lumbricals 3 and 4, okay? And then all of the interossei muscle, regardless of whether you are dorsal or you are palmar interossei, you are still going to be innervated by the ulnar nerve. So the ulnar nerve plays a major role, a major role, okay, here in the hand. How about skin innervation? How about cutaneous innervation? Here it is. Cutaneous innervation on the palmar surface of the hand are going to be all of the things that are not innervated by the median nerve. That includes the medial 1/2 of the ring finger, okay, right here on the palmar side, as well as the pinky finger on the palmar side, as well as all of this thing, okay, all of this area right here, okay, that is on the forearm region. Now, more extensively than the median nerve, the ulnar nerve also innervates a very fairly large region of skin right here, okay, on the dorsal surface of the hand, okay? So that's all ulnar nerve innervated skin region. And you can feel it as well. Remember when we said that the medial epicondyle of the humerus contains a groove that is called the ulnar groove? That's your funny bone, right? So if you happen to strike your funny bone onto a hard surface, you may feel, okay, that there is an electrical current. And that electrical current, if you follow its progression, it is going to go from the medial epicondyle all the way down to these fingers. Specifically, next time you have that sensation, check it out. You will see that I am true, okay? And so all of these skin regions are all going to be innervated by the ulnar nerve. This is very important. All right, so our last nerve is the radial nerve. As it travels to the hand, the radial nerve will give rise to no muscular innervation branches, simply because of the fact that the ulnar nerve and the median nerve has already taken care of everything. And most of the contents of the hand are going to be on the palmar side anyway. And so because of that, the radial nerve will play no role here, okay, in terms of muscular innervation. However, it does supply an area of skin. That is this side, the lateral side, okay, of the skin of the proximal thumb on the palmar side, okay? And on the dorsal side is this region right here, okay? That is going to be of the thumb on the dorsal side, of most of the index and middle finger on the dorsal side, except for the very, very tip, which are going to be the median nerve territory. So only at the hand, the radial nerve gives rise to no muscular branches, but it does give rise to some cutaneous branches that have the effect of innervating the sensations from the skin region as you have seen here. All right, so in summary, for hand muscle innervation, we have the median nerve is going to innervate the first and second lumbricals, the opponens pollicis, the abductor pollicis brevis, and the flexor pollicis brevis, aka a loaf of bread, basically. The ulnar nerve is going to innervate everything else, and the radial nerve will have none for hand muscle innervation. For cutaneous innervation, these on the right side will show you the cutaneous innervations of each of the nerve, the ulnar nerve, the radial nerve, and the median nerve on the palmar side, as well as on the dorsal side of the hand, as you can see here. Okay, so finally, let's go on to some clinical correlates. All right, so the first clinical correlate we have already seen before, carpal tunnel syndrome. So carpal tunnel syndrome is what? Is the compression of the median nerve as it travels within the carpal tunnel. There can be many causes of the carpal tunnel syndrome, but most often than not, it is the compression, okay, of the median nerve by a swollen tendon or a bursitis causing the bursa to increase in size and compress the nerve, okay? And for the carpal tunnel syndrome, there are some signs that can be associated with carpal tunnel syndrome, including pins and needles sensation in the distribution area of the median nerve, except for the skin on that metacarpal surface of the thumb side of the hand, on the palmar side, due to the fact that that area is innervated by the palmar branch of the median nerve, which did not travel through the carpal tunnel. Also, weakness and loss of muscle bulk of the thenar muscles, the three major thenar muscles, OAF, may also occur. If the median nerve is compressed so much for a prolonged period of time, these muscles will stop functioning, and you end up not being able to oppose your thumb, which is a huge deal for patients because they need to oppose their thumb, for example, to button their shirts and do all kinds of stuff in their daily life. So if the thenar muscles, especially the opponens pollicis, is affected, then there would be a whole lot of repercussions for the patients. Now, gently tapping over the median nerve in the region of the flexor retinaculum of the carpal tunnel will produce some of the symptoms. So it will increase the pins and needles feelings in the distribution of the median nerve. Basically, you will feel as if this area that is innervated, the area of the skin on the palmar side that is innervated by the median nerve, is going to have these prickly feelings, the pins and needles feelings, and it will increase as you tap on the region of the flexor retinaculum at the anterior surface of the wrist. This is called a Tinel sign. Okay, and for the treatment for carpal tunnel syndrome is going to be depending on the stage of the disease, basically. So if you are in an early stage of carpal tunnel syndrome, you can take medications, okay, anti-inflammatory medications. If the disease is a little bit more severe, you can inject that anti-inflammatory medication right into the carpal tunnel, right into the region of the carpal tunnel. And for example, corticosteroids, you can inject corticosteroids, which is a powerful anti-inflammatory drug, into that region, okay? And then for the last-ditch effort, if everything else fails, then you can always use a knife and cut open the flexor retinaculum, spilling the contents outside and release the tension on the median nerve. All right, so ulnar nerve injury. What type of hand sign is visible in an ulnar nerve injury? It is a claw hand. The shape of a hand is going to assume the shape of a claw. And why is that? It is because of the fact that you have, instead of the flexion of the metacarpal phalangeal joints and the extension of these interphalangeal joints, you got the opposite, which is the extension of the metacarpal phalangeal joints and the flexion of these interphalangeal joints, causing a claw hand. Okay, and of course, the ulnar nerve injury is going to cause damage to all of the muscles, including the interossei, as well as the muscles of the hypophyseal eminence and the two lumbricals on the medial side of the hand. And the radial nerve injury. Radial nerve injury really does not affect anything onto the hand, except for the fact that you will lose the sensation on the skin surface of dorsum of the hand, especially, that is innervated by the radial nerve, okay? But really depends on whether you have a radial nerve injury that happens way up. Like, for example, the radial nerve injury is actually a terminal branch of the brachial plexus, okay? And that terminal branch is going to first wrap around the humerus, okay? And it travels within an area of the humerus that is called the radial groove. Now, if you damage that radial groove, for example, in a midshaft fracture of the humerus, then a radial nerve can get damaged there. And if it can get damaged there, then it's not going to affect the triceps brachii muscle, because the branch that goes to the triceps brachii muscle has already taken off from the radial nerve at that point, but it will affect everything else down the line, okay? And if you have everything else down the line that is affected, as in the case of all of the posterior compartment muscles of the forearm being affected, what do you think the result will be? Will you be able to extend your wrist at all? No, you can't. We call that a wrist drop injury, okay? And so radial nerve injury is going to produce wrist drop if you produce the injury before the branches to the forearm, the posterior forearm muscles, have taken off from the radial nerve. All right, that is all for today, folks. Thank you very much for accompanying me throughout this wonderful journey of the upper limb. Next lesson, we will go over to the lower limb, and be sure to look at the context of this lesson and review the materials for subsequent quizzes and exams, as well as simply just deepen your knowledge in general. And make sure that you check out the book as well, in order for more information, okay? And that's only can be good for you on the clinical aspects of things as you go on to later years. My name is Quang Nguyen. Thank you very much for accompanying me today, and I will look forward to seeing you on the next classes. Bye-bye.